Good evening. I want to thank you for the invitation. I want to thank Ben. I want to thank Jen for the invitation to talk. I specialize in male and female sexual dysfunction and testosterone replacement therapy. So I have about an hour and 15 minutes to give you the overview of everything, and hopefully we will. There's several topics I want to get through tonight. I first want to go through a little bit about how we got here with the drugs and medications that we use today. I'd like to talk about the current ED treatment options. A patient walks into your office today, has erectile dysfunction. What can you offer them? What's available? I want to talk about a different way of thinking about erectile dysfunction. Erectile dysfunction is a disease. It is a progressive disease. It is not a symptom. And so we should think of this like a disease, like we treat other diseases. How do you treat the female partner? Because that's the other half of the story, and I'll show you why. Potential future ED therapies, testosterone controversies, and then I'm going to go through a little bit about Peyronie's disease, the patients that walk in with premature ejaculation, and what we don't talk about a lot is delayed orgasm or delayed ejaculation, and how would you treat those patients. So we have a lot of work ahead of us, so let's do it. So a little bit of history, just to let you know, ED has been treated for thousands of years, and earlier descriptions of the literature describe ingestion of testicular tissue. That's what they used to do. Ancient Egypt, in India, to eat the testicular tissue would give them energy, would give them potency. It wasn't until in the 1500s we realized that ED is a vascular disease. You need the blood to stay in the penis. If the blood does not stay in the penis, it's called venous leak, and the man cannot maintain his erection. It wasn't until the 1800s that we figured out it's a nerve issue as well. If the nerve is not providing the signal to the penile tissue, the patient does not get an erection. 1935, we got testosterone. It was a big year. One of the biggest years was 1973, not to brag, but at Baylor College of Medicine, our institution, Brantley Scott invented the penile prosthesis, which is used throughout the world, right? So theoretically, any man who's willing to have a penile prosthesis can be cured for ED. Starting in really 1996, for the next 20 years, an explosion. You get Edex, you get Viagra in 1998, you get Cialis in 2003, you get Avanafil in 2012. So really an explosion in the amount of drugs that are available to treat men for erectile dysfunction. So if you open a magazine, you open a book, it's going to tell you this statistic, and unfortunately this statistic is so old, it's from 1994 and they still use it. It's from the Massachusetts Male Aging Study. Roughly 52% of men have some degree of erectile dysfunction, whether that be mild, moderate, or severe. I want you to think about that. 52% of men between the ages of 40 and 70 suffer from this condition. Now when patients come into my office, they say, "Doc, how did this happen to me? How did I get ED?" And I explain to them it is a natural part of aging. Every single man, if they live long enough, will get erectile dysfunction. If you look here, 40% of men at 40, 50 at 50, 60 at 60, 70 at 70, you live to 100, 100% of men will get ED. It is a natural part of aging. There is no choice. But what we can do is we can do things to shift the curve. So if you're going to get ED at 65, we can do things to make it happen at 75 or 85. We can always shift the curve. So there are many causes for erectile dysfunction. In medical school, they taught me the mnemonic VENT, V-E-N-T, vascular, endocrine, neurologic, and trauma. The number one cause being vascular, and the number one cause underneath that being venous leak, right? So an erection is pretty simple. Blood has to come in, and blood cannot come out. Basic concept, right? But the number one cause of ED in the world is that the blood comes out too quickly, and that's called venous leak. So what does the patient tell you? "Doc, I can get the erection, I just can't maintain it." That's the number one cause. What he's trying to tell you is, I've developed venous leak, right? So vascular being number one. The other killer is antidepressants, right? So many patients are on SSRIs. You have to be very careful. And on the urology boards, it's the beta blocker. You put someone on a beta blocker, they get ED, right? So be very careful when you put them on a beta blocker. So the problem is that there are many patients out there who don't get treatment, right? There's several studies out there showing that roughly 75% of men who have ED don't get treatment. Another large study, 77%. Why do the men with ED not get treatment? One, they're embarrassed they have ED. They don't want to tell you they have ED. Number two, there's a concern that the physician won't take them seriously. And most importantly, the MDs really don't address the issue. So I'll give you a little anecdote. My wife is a family practitioner, and she takes care of a lot of patients, and she says, "Look, you know, I have to go through hypertension, hyperlipidemia, OSA, and I cannot get to ED in 17 minutes, right? You know, so it's the last of the thing that they get to, right? So it's really never discussed, and it's really an unmet need. Many patients are seeking a location to talk about their ED and to seek treatment. So these are the guidelines that came out with the European Association of Urology. The American Association of Urology, we have old guidelines. I'm currently involved in the development of new ones, which will come out in 2017. So I'm going to present you the European one. And the European one basically says this. A man walks in, he says he has ED. We typically use a questionnaire called the IIEF. I'm sure you're familiar with it. We use it to screen men for erectile dysfunction. And what you want to do is you want to make sure they don't have other causes of sexual dysfunction. Premature ejaculation, Peyronie's disease, delayed orgasmia. You want to make sure that they're not smoking, they're not in an SSRI, anything that could be reversible as well. We typically do an exam. We look for signs of cardiovascular disease, and I'm going to go into that in much more detail. But on our boards, you have to get 3 tests. You have to get the testosterone, you have to get the lipid panel, and you have to get the hemoglobin A1C. Those are the basics. Now you can get a thyroid, you can get other things also, but the basics are the testosterone, the hemoglobin A1C, and the lipid panel. So they walk in, and this is really the evaluation. So how do you treat them? So the first line therapy is really not going into drugs, but it's really lifestyle modification. Everyone skips lifestyle modification, right? But that's the key, right? It's diet, exercise, sleep, and stress reduction. Those are the key to reversing the ED process. But if those aren't successful, you can start talking about a PDE5 inhibitor. Remember that a patient has to try a PDE5 inhibitor at least 3 times. Some studies will say 8 times before you say that it's failed, right? Because when you give a man Viagra for the first time, what do you think he does when he takes that medication? He's nervous. He has a huge adrenergic response, and he cannot relax, right? And it doesn't take at least several times to make sure it doesn't work. Secondly, he's got to take it on an empty stomach. When do men have sex? They go out and have a nice dinner, they have a couple glasses of wine, and then they take the Viagra. Will not work in that condition. You take the Viagra before you go to dinner at 5 o'clock. It will not wear off until 2 o'clock. You're fine, but you take it before dinner, not after dinner. Jen?
Does that pertain also to tadalafil and vardenafil, or those are better with food as far as I
So
know?
the only one that can be taken with food is tadalafil, but it's a 2-hour onset, and so is Avanafil. Avanafil can be taken with food also. The problem is even though you can take it with food, it still inhibits the concentration, right? So it's not as efficacious. So yes, you can take it with food. But if you really want to tell someone, look, your best chance is you take it on an empty stomach, then you go out to dinner, it's far more effective than taking it when you get home. Far more effective. And you try it a couple of times before you say it's failed, right? So we believe it's important to use those medications several times. So this is the algorithm that has been really used. I call it first line, second line, and third line therapy. First line therapy is easy. It's meds, right? It's medications, phosphodiesterase inhibitors, Viagra, Levitra, Cialis. We get more into second line therapy. You can use urethral suppositories like Muse. We now compound it so you can get Trimix gel, which is a fraction of the cost because Muse is $60 a pellet. Injectables like Edex or Caverject, Trimix as well, and a vacuum erection device. If these tend to fail, then we go into third line therapy, which is a penile implant or corrective vascular surgery, which I do very rarely, right? So I just want to point out 99% of what I'm showing you for the treatments, because this is all we have, is not a cure for ED. Right? It's just putting a Band-Aid on a problem. No, these aren't cures, right? They're just, the disease is getting worse every year, and you're just trying to cover it while the disease gets worse, right? Remember this, I'll give you an example. You break your leg today. I have 2 choices. I can give you Vicodin every day, you can function, or I can fix your leg, right? These are just Vicodin, right? It's just Vicodin as the disease gets worse. It's not fixing the problem. And I'm going to show you a different way to think about the problem. Just a comment on sildenafil, tadalafil, vardenafil. Half-life on Cialis is a lot longer at 17.5, so typically it lasts at least 36 hours. Men will take it on Friday at 5 o'clock. That's what we tell them. Take it Friday, 5 o'clock. You're covered Friday night, Saturday day, Saturday night, Sunday morning, right? You don't have to think about it. So that's one of the benefits. It does take a little bit longer. I know it says 60 minutes, but it does take a little bit longer to get into the system. So typically, if someone has a risk for an MI, you don't want to give them tadalafil or Cialis, because if they have a heart attack tomorrow in the ER, I still cannot give them nitroglycerin, right? So you can't give him nitro. If you give him Viagra, he can take nitro tomorrow, but you can't give him nitro when he took Cialis the day before, right? If someone has an arrhythmia, you don't want to give him vardenafil because it will prolong the QT interval, right? So you don't want to give someone Levitra if they have an arrhythmia, right? Avanafil is the newest one. It's the only one that's FDA approved for 15-minute onset, right? So 15-minute onset is the only one that it's approved for. It can be taken with food and water, food and alcohol, excuse me. And it can also, the only other thing you want to remember is that it's very specific for phosphodiesterase type 5. So just to recap, there's 11 phosphodiesterases in the body, right? And so you have 6 in the retina, you have 11 in the back. If you have cross-reactivity with 6, you get a little blue tinge vision. Cross-reactivity with 11, you get some back pain. Vanaphil is very specific for 5 and nothing else. So you don't get a lot of the side effects that you see with the other medications. So if someone complains of side effects, you may say, hey, have you tried a Vanaphil? It may have a better outcome. Just to comment on, if you look at the market with Cialis, Levitra, the only one that's really growing is Cialis, and it's the daily. In my opinion, there's not a better drug for ED than daily Cialis, and I'll show you why. Daily Cialis, in my opinion, is a cure to the disease. If you look at the penile muscle, what happens if you don't use it, it atrophies. I put your arm in a cast today, take it off the cast after 6 months, it's atrophied. The penis is just 2 muscles. That's all it is, just 2 muscles running in parallel. So if you give patients daily Cialis, what you see over time is hypertrophy of the muscle. It becomes larger, right? Hypertrophy of the muscle, reversal of the ED process. It's like going to the gym is what I tell the patients for the penis. Whether you're having sex or not, every day putting blood and oxygen to the penis. The other thing is it actually works pretty good for BPH, for urinary symptoms, right? It's FDA approved for BPH. And in fact, if you write for BPH, many times you can get coverage, insurance coverage for the BPH side, but not for the ED side. So it does work. I put this in here for a reason, and because when I ask the residents, I say, what are the contraindications for phosphodiesterase inhibitors? They all say, oh, well, doc, it's so easy, you can't take nitroglycerin. But if they're not taking nitroglycerin, you can give them anyone a phosphodiesterase 5. That is not true. And in the package insert, you should read carefully what it says. And what it says is that those patients with the following characteristics, so resting hypotension, uncontrolled hypertension, unstable angina, New York Heart Association Class 2 or greater CHF, hereditary disorders like retinitis pigmentosa, including, on these conditions, these medications have not been tested, and it is not recommended to give patients these medications. Medical legally, if you give someone this medication with this condition, it's really hard to defend because they're telling you here, don't give it to them, right? It's very important, right? So it's not just nitroglycerin, you can't take it. There are certain conditions where you do not give someone a PDE5 inhibitor. So testosterone, a lot of people use it, a lot of people treat with it. When I started medical school, I was taught, it was a board question that year, testosterone only affects libido, it has nothing to do with erections. That is not true. Testosterone is very effective in a man's erections, but as monotherapy, it's not that phenomenal. I mean, if a guy walks in with full-blown ED and you say, I'm going to give you tea and your erections are going to be great, probably not. It will help as monotherapy, maybe in 15% of the time. Combination therapy, it's very effective, right? So we know that testosterone affects nitric oxide in the penis, very important. It helps with veno-occlusive disease, keeps the muscle very strong in the penile tissue. It's important for cavernosal nerve function, but also, very interesting, testosterone is very important in the way it regulates phosphodiesterase type 5, PDE5 inhibitors. Strong correlation between Viagra, Levitra, Cialis, and testosterone. And the best example I can give you is this. When the testosterone levels get low, the efficacy of the Viagra decreases. When you replace the testosterone, the Viagra starts working in 30 to 50% of patients, right? Very synergistic, right? We published one, and this was in 2011. I published a series of 850 patients. We showed that those patients who, when you gave them testosterone supplementation, PDE5 inhibitors became much more effective. And what's very interesting is that even if you were already on a PDE5 inhibitor, taking TRT actually enhanced your erections as well. So again, very synergistic. And these two medications should be used together. Intracavernosal injection therapy, very effective, but there's some caveats. Remember that you increase your risk for Peyronie's plaques, you almost double it from 9 to 18% because you're chronically sticking a needle into this plaque. We only let them inject at the 2 and 10 o'clock position. You must alternate sides, and you can only do it 3 times a week to mitigate the plaque formation, so that does help. And it's very important to do the test dose in the office because, again, you can titrate. What you don't want to do is then have a priapism, and then we have to take it down in the ER, which could be an issue, right? So, again, alternating sides. Most commonly used in the industry is Trimix, even with urologists, right? Because it's cheap, it's very effective, and I can put any formulation I want. I can make it half strength, I can make it bimix, I can make it trimix, I can make it quad mix. I have complete liberty of changing any way I want to. Remember that if someone complains of penile pain, take out the Prostadil, right? Prostaglandin is what causes the pain. So you just give them bimix or super bimix, but you don't give them trimix with penile pain. When someone has a radical prostatectomy, they have undergone a neuropraxia. And patients with a neuropraxia also are very sensitive to prostaglandin. So you take it out, right? You give them just the Biomix, no prostaglandin. There are some companies that are now making lyophilized Trimix, because many of my patients say, look, I love to take the Trimix, but I like to travel, and I don't want to refrigerate it and carry a kit. And so now you can get lyophilized Trimix, where basically you take the saline and you put it into these vials individually, and then you drop what you need at one time, and it's disposed of. It does not need to be refrigerated. So again, very convenient. Because this is the real convenience of Edex. Edex was it didn't have to be refrigerated, so people liked it, but it's $60 each one, and these typically come out to $3 or $4 for each injection.
Can I ask you a question?
Sure.
Is that okay?
Sure, of course.
I had a patient just this week who said to me that he was using his Trimix daily for 2 weeks at a time, and then he wouldn't use it for another 2
Yeah.
weeks. And he said sometimes it works and sometimes it doesn't. And I said, really, it's supposed to be 3 times a week. What is the danger of that?
So it's really, the danger is scar formation. It's scarring, right? Because you can develop a significant Peyronie's plaque. And if the plaque is greater than 60 degrees, it's prohibited for intercourse. And you know, I'm going to talk about Peyronie's. Not a lot of treatments out there. There's only one FDA-approved treatment. So that's the danger. It's the scar form. It's the repetitive trauma to the same location is an issue with a needle. That's the issue.
So should he be moving his injections to where
You
that
can,
cause more
you
scarring?
can, but it's just more scarring. You need the tunica to have some, even in the best case scenario, if you inject every other day on opposite sides, you still double your risk for Peyronie's.
So I can just,
You still
know,
double
give
your
him a
risk.
statistic,
Yeah.
that will be enough
You still
to
double
convince
your
him
risk.
not to do that?
Yeah. This is Muse. You're familiar with it. It's expensive, but it's a prostaglandin suppository. Comes in 125, 250, 500, and 1,000 micrograms, and it's pretty effective in combination therapy. It is not great, in my opinion, in monotherapy. Right? If someone comes in and wants to use Muse, I say, okay, you took Viagra, you got 70% rigid, and you cannot penetrate. See, I said, do you want to use injections? He says, absolutely not. Okay, so then you can use Muse in combination with Viagra, and that's very effective in getting you the 30% more without having to use an injection, right? So combination therapy is very effective, or you can use a Trimix gel, which is a lot cheaper, but this is where this is very popular. This is just a schematic where they place it into the urethra, drop off the suppository. Within 5 minutes, they get some rigidity. But again, as monotherapy, not great. Combination therapy, very effective. Vacuum erection devices, you're all familiar with vacuum erection devices. They can be bought over the counter. They can get a prescription. It's exactly what it is. It's a vacuum. The benefit about a vacuum erection device to me is really rehabilitation, right? You know how you go to the gym? Same concept. 1 minute up, 1 minute down with the vacuum erection device. It's been the only thing to show to increase penile length, increase penile girth safely without us having to do a surgery like cutting the fundiform ligament. It's safe, right? So increasing penile length, increasing penile girth, and it gets hypertrophy of the muscle. Very, very important. But one of the problems is that it's not great in terms of bringing in 100% arterial blood, right? So 42% of it's venous, and 58% of it is arterial. So when patients are rehabilitating in my practice after post-radical, we tell them I need 3 erections. Vacuum doesn't count. It can be with Viagra. It can be with an injection, because that's 100% arterial, right? And this is more for tissue expansion and preservation of the tissue, right? Because it's not 100%. It's 42% venous. So the implant, you're familiar with it, but just so you know, there's basically 3 components. There's a pump that goes into the scrotum. There's 2 cylinders that are placed into the penile bodies, and then there's a reservoir. The patient will squeeze the pump. It'll pull normal saline out, induce an erection. When he finishes engaging in sexual activity, he'll release it, and the fluid will go back, right? The surgery takes about an hour. If you look at satisfaction rates out of anything we do, survey after survey after survey, this one blows all of them out the door. It's typically 95% or higher for the patient and 95% or higher for the partner as well, where PD-5 inhibitors are typically 50% and injectables are 40%, right? It's night and day. It's just the phobia of having an implant in their body. But once they get over the phobia, they love it. I mean, the satisfaction is very, very high. So we're going to switch gears, right? Because everything you learned about ED, I want you to erase it in terms of the way you think about it, right? It's a disease, just like diabetes is a disease. It's a disease process as we get older, right? And so it's a different way of thinking about it. There is a strong correlation between erectile dysfunction and cardiovascular disease. In fact, if a man gets ED today, 15% of them will have a heart attack or stroke within 7 years. ED today, 15% will have a heart attack or stroke within 7 years. Interesting concept. So how does it occur? So Montorsi came up with a theory called the arterial diameter theory, and it makes a lot of sense. What he said was that, look, the penile arteries are the smallest. They're 1 to 2 millimeters. We know that the coronaries are 3 to 4 millimeters, the carotids are typically 5 to 7 millimeters, and your peripheral arteries are typically 6 to 7 millimeters. And if you remember from physiology, you need 50% occlusion of a lumen to cause end organ damage, right? 50% occlusion. If you're going to occlude an artery, which artery are you going to occlude first? Remember, you're much more likely to get ED before you get a heart attack. You get a heart attack before you get a stroke. You get a stroke before you get peripheral vascular disease. It follows the order, right? It always follows that order, typically, right? So ED is your body's way of telling you there's something going on, right? There could be an issue with blood flow in other parts of the body. So the link between ED and cardiovascular disease is the endothelium, the lining of the blood vessel. Remember, that's the brains. There's nothing smarter, more incredible than the lining of the blood vessel. It detects what's in the blood. The computer tells it whether it should contract or relax. If that endothelium is damaged, it becomes stiff, then there's a plaque, and then you got trouble, right? So you want to keep the lining of the blood vessel healthy, and the healthier it is, the healthier the patient. So there are markers in the blood to tell you how healthy your lining of your blood vessels are. You've heard of these, IL-6, C-reactive protein. It tells you how healthy the lining of the blood vessels are. You can do some imaging, but also what we do at Baylor is we use a machine, a technology called PAT, peripheral arterial tonometry. Right? It's a pretty interesting phenomenon. Basically, the patient will put a blood pressure cuff on their arm. We put a probe on the finger. We put another probe on the contralateral finger. We raise this up to supraphysiologic levels, and then we release it. When we release this blood pressure cuff, we look at how well the finger dilates in response to this release and gush of blood. If it's able to dilate very well compared to the contralateral finger, that's good. You have healthy blood vessels, right? And they use an index called the RHI, the reactive hyperemic index. And the cardiologists in 2004 at the Mayo were the first that went crazy with this. And they did PAT technology, they did this on every single patient, then immediately wheeled them into the cardiac cath lab, and they started doing cardiac caths on them, and they found a very strong correlation between low RHIs and occult cardiovascular disease, 2004. So in 2008, we said, that's pretty interesting. We bought one of these machines and said, okay, as a urologist, we actually have penile ultrasounds. We're going to copy the same study. We're going to give all the patients this machine, then we're going to wheel them directly into the lab, and we're going to do a penile duplex. We found the exact same thing. If you have a poor RHI score, it significantly predicts those patients that will have arterial insufficiency in the penile blood flow, right? So it tells you that this technology, the lining of the blood vessels, is a systemic disease. It's not just happening in your finger, right? It happens all over your body, right? And it's a surrogate marker for your heart, penile, carotids, everything in the body. So we want to protect. We really want to protect the endothelium because we're protecting cardiac, carotid, and penile blood flow. So some of the smartest doctors out there, and I hate to admit it because I'm a urologist, but they're really the cardiologists. The cardiologists figured it out because Dean Ornish, all those studies when I was in residency, they figured out that if they improve the endothelium, they can actually reverse cardiovascular disease. They can reverse the plaque in the heart. It was a pretty amazing study just on diet and exercise. So they said if we improve the endothelium, we improve the cardiac blood flow, and we can actually treat coronary artery disease. And some of the studies in the cardiac literature, they had diet and exercise was improving the endothelium, statins improved the endothelium, insulin resistance, aspirin, smoking cessation, even some are using chronic PDE5 inhibitors, and believe it or not, with the controversy, some were using testosterone to improve the endothelium to reverse cardiovascular disease. So I thought to myself, okay, listen, if we believe that the endothelium is the common link between ED and cardiovascular disease, and the cardiologists already figured it out, all I have to do is just copy them and use their paradigm to treat erectile dysfunction. If it's true, right? Copy their paradigm to treat ED. And there is phenomenal data to support that diet and exercise, statins, smoking cessation, chronic PDE5s reverse the ED process. So I'll show you a couple. Esposito in 2004, amazing study. It was a JAMA study, 110 obese men. She said, okay, 55 of you are going to do a diet and exercise program, 55 of you are not. I'm going to follow you for 2 years. They had ED to be in the study. And if you were on a diet and exercise program, you lost weight. That's great. You also saw a significant improvement in markers of endothelial function, which was interesting. And you had a significant improvement in erectile function only by diet and exercise alone. So no Viagra, no Levitra, if you just did diet and exercise alone, in our literature, a movement of at least 2 points is significant. This was 3. Just with diet and exercise alone, you reverse the ED process. And it was an independent variable, ED and diet and exercise. So statins. We were taught initially maybe statins are bad for ED. That's not true. There's a small study. This is a small study looking at 18 men who were not able to get erections. They were starting atorvastatin. They had high LDL levels. After 4 months, 88% of them on a statin alone had significant improvements in erectile function. They had significant improvements in Rigiscan, which is objective. It's measuring nocturnal erections with a meter around the penis, right? So this is objective, improvements in Rigiscan scores as well. Another small series looking at men who failed Viagra. So you fail Viagra, you start a statin, then you take Viagra again, and you get non-responders to become responders to PDE5 inhibitors. Very similar to what I showed you with testosterone, right? But now with statins as well. Similar study, by 6 weeks, those patients that were on statins, significant improvement in erectile function scores again. So interesting concept of using a statin as a treatment for ED. The largest study on statins was a meta-analysis, 11 randomized studies assessing the treatment of statins for ED. Significant improvement in erectile function scores. In fact, the statin was almost 1/2 as effective as a Viagra. 1/2 as effective as a Viagra, improving overall erections, and very, very significant. So we use statins a lot. Typically in our practice, we use quite a bit of statins for the treatment of ED. Yes?
Do you normally use 80 milligrams?
No. That was theirs, yeah. So I typically use Crestor, and I'll start with 10 low, and we'll kind of move up. The thing is, I'm a urologist, so I have to work very carefully with the internist, right? Because he calls me up and says, "What are you doing on my patient?" And so you have to really work with him. But I never start that high. Yeah. So I told you earlier about this importance of daily PDE5 inhibitors, and I'm not going to show you all the data, but I will show you Aversa's because his was so compelling. So Aversa, what he did was he gave him daily versus on-demand Cialis. Daily versus on-demand Cialis. He measured peak systolic flow, that's ultrasound. He measured questionnaires. He looked at endothelial markers. What did he find? So if you took the daily Cialis, much better blood flow on the ultrasound after you took the daily Cialis after 3 months. You had better improvements in endothelial function. Even the markers of endothelial function significantly improved, but this was a clincher. Let's say you stop the daily Cialis versus the on-demand. The benefits were seen 3 months after discontinuation. 3 months, statistically significant, after discontinuation of the medication. Sorry? So I typically use 5. I use 5, but you can...
He said, I thought 20.
Well, he used 20. It was on-demand. It was on 20 milligrams on alternate days of chronic treatments or so. So the reality is you can take patients, if patients were engaging in sexual activity every day, they could theoretically take a 20 every day, right? There's no contraindication, right? And so, so typically we start with 5, and we usually compound it because 5 daily is expensive if you have to pay cash. So typically the compounders will make a 3 or a 7 for patent infringement. They can't make a 5, right? So we get 7s for most patients or 12s daily. 7, I don't go any higher than 12s, right? 7 or 12s, and they're very cheap and they're very affordable. It's the same thing as Tadalafil, you know? But very impressive, yes?
Do you have to take the lower dose on an empty stomach too?
You don't have to take Tadalafil on an empty stomach. And remember this, because it lasts 36 hours, but I do think personally that the efficacy is better if you do, right? They say you don't, but I think the efficacy is better if you do. What's nice about it is it doesn't matter when you take it because it's 36 hours, right? So you can take it in the morning, afternoon, between meals every day, it doesn't matter, right? And remember the multiplication is 1.6. So if you're taking it every day but it lasts 36 hours, the multiplier, if you're taking 10 milligrams, you multiply, it's 1.6, so it's 16 milligrams is what I effectively have when I engage in sexual activity, right? So it's a 1.6 multiplier, right? Okay, so why is daily, a couple more comments. The first one came out in 2008. Padma Nathan shows those guys that had a radical prostatectomy, if I give them daily Viagra versus placebo, they are 7 times more likely to recover their erectile function. 7 times. He was the first to show it. But it got more interesting because Schwartz did something very interesting. He took 11 patients and he gave them sildenafil 50 milligrams or 100 milligrams every other day, okay? And then he started after the catheter was removed. But he got something interesting. He biopsied their penile tissue at the time of radical prostatectomy when it was healthy, and he biopsied it 6 months later. I'm not going to present to you all the data, but at 6 months with no intervention, we see a significant amount of fibrosis and scarring in the penile tissue. You get apoptosis at 6 months in most men. It's pretty fast. So this is what Schwartz found. If he gave these patients 50 milligrams of Viagra, there was actually no change, no difference in the smooth muscle content. They preserved it, right? They preserved it. What's more striking is if you gave 100, it actually got bigger. It hypertrophied, right? So it's like going to the gym, right? It's reversing the ED process. And that's why I think daily Cialis is so important. It's really causing hypertrophy of the muscle. So typically this is what we do. I'm not going to go through this, but we do some laboratory testing, testosterone, hemoglobin C. We look for lipid panel. You should look for other things too, and I know you guys are very thorough with thyroid, and we look at prolactin. You look at other issues like DHT, estradiol. We do the specialized testing. We do biothesiometry, endopat. But we're very big on lifestyle modification, and I can't stress that enough. And the part we stress the most is the 4 pillars. And I go over it every single time when they come in, and I know you guys do the same thing. And the 4 pillars are diet, exercise, sleep, and stress. Each one of these independently is stronger than any drug I can give you, right? Each one independently, by itself, is stronger than any drug I can give you. And could you imagine if the patient was doing all 4? They're unbelievable. They're just a complete body life change. And each one of these independently can affect each one of these 4: mental health, sexual health, physical health, and hormonal health, independently. So if you're doing them together, you get a very synergistic effect on all 4 quadrants. So this is really the core. Patients come in, they say, I just want my Viagra and my testosterone. It's a lot more than that, right? It's a lot more than just the Viagra and the testosterone. A comment on female sexual dysfunction. I know Jen's here, but I do a lot of this as well. And the reason I did a lot of this was in 2007, when I started my practice, I would get these guys to come in, and we would finally get them to have these amazing erections and this great libido, but they'd had no one to have sex with, right? They have no one to have sex with because they went home and their wives were postmenopausal, they hadn't had sex in 10 years, and many women were actually very upset. They called, one threatened to sue me. Yeah, one threatened to sue me. She said, look, everything was fine until he met you. Right? And now he chases him around the house. He wants to have sex all the time. And it's true. You know, the reality is either you leave both libidos low or both high. You never want one high or one low in the house, right? It's got to be the same, right? The problem is that these guys want to raise their libido, but they don't think about the other half, right? And so you got to raise the other half. So just a comment on, it's a couple's disease. It is not just focusing on one person. There's no point in improving one partner's erections or sexual function without knowing what's going on the other side. Makes no sense. Makes no sense at all. So just a few comments. We know that all those guys that have ED, 43% of their wives at home have some degree of sexual dysfunction. And out of those wives that have sexual dysfunction, only 9% of those population are getting any form of treatment. 91% are not.
Are you using a questionnaire for females? And if so, which one?
Do I use a questionnaire? I use the FSFI. It's the most commonly used. It actually is the most commonly used. It's a great questionnaire. 6 domains, and I think I have it here. These are the 6 domains that we typically use. But it's really good in pinpointing what the problem is. You know, we know that women who have sexual dysfunction, 1/3 of their partners at home have ED, right? It's very, very well correlated. But this is the clincher. So Irwin Goldstein in 2005 did the landmark study. What he said was this: I'm going to give half the guys Levitra. I'm going to give half the guys placebo. I do not want to meet their wives. I don't even want to talk to their wives. But I'm giving every single one of those wives an FSFI questionnaire. Okay? And I want to see what happens to their sexual function. So those men that got Levitra, guess what? Their erections improved. But their wives' sexual function significantly improved. Their libido, their overall satisfaction. He didn't meet them. He didn't touch them, right? But a statistically significant increase in their sexual function. Those men that received placebo, their wives didn't have any change at all in their sexual function, right? So at Baylor, we switched the study. We did the same thing with testosterone. We gave all the women testosterone, and we didn't want to meet the men. And we wanted to give the men, though, an IIEF. Without even meeting the men, IIEF scores go up, just like a Viagra would go up, right? So what am I trying to tell you? One of the best ways to improve a man's erectile function is to skyrocket his partner's libido, right? It's very effective, right? But it's not taught of. It's a very effective way to treat them. So you can give the man testosterone, Caverjet, you can give him an implant, you can give him Viagra. You got to treat the female partner, right? You have to treat the female partner. That's part of it. It's just as effective.
Or the male.
Right, or the male, right? So we published this several years ago, and we published this on post-radical prostatectomy. You know, when we do these radical prostatectomies, people brag on their ED rates. Oh, my potency rate's 100%. When I do this surgery, my potency is 90%. It doesn't make any sense whatsoever. The reality is that it all depends on if you have a partner at home that wants to have sex, right? So those guys, if I operate on them, and they all have wives that are young, newly married, those guys recover pretty quick. Those guys that I operate on, and they have wives at home that do not want to have sex with them, those guys take forever to recover, right? The female partner dictates who's going to be compliant to a rehabilitation program, and they predict the rate at which men will improve their erectile function. When we published this in 2010, and it holds true. So when we treat men for ED, you got to treat the female partner. Men and women are very different. Men are very easy. They come in, I give them testosterone, I give them a little Viagra, and they're done, right? Women is a little more complicated. It's not as easy. So women, lifestyle modification, weight loss, you know, we do a lot of pelvic floor exercises for orgasmia and vaginismus. But again, as you mentioned also, we treat the male, right? On the flip side, you want to do the same for the women. You want to treat that man's erectile function and libido. There are, in women, just one comment. We do hormonal therapy. I call it the triangle: estrogen, progesterone, and testosterone. I think it's very important to find that balance. We also use non-hormonal therapy as well. Anything that increases dopamine in the brain will increase sex drive. You may have seen the commercial for Mirapex and Requip. Those are for restless leg syndrome. So you remember the announcer, what he says on TV? He says, if you have increased gambling urges or sexual desires, notify your doctor immediately, right? Because it increases dopamine. So we use it for the side effect, right? For Mirapex and Requip is very, very effective. One comment on AD-D. In 2015, in October, we had 26 drugs for men for sexual dysfunction. We had 0 for women, not one. Right? You couldn't walk into Walgreens to get the drug for women. But in 2015, in October, came out the first drug to treat women for sexual dysfunction. They take this every day, and it increases their libido and desire for sex. There's been some mixed reviews on this so far, but we do have a drug to treat women for low sexual desire. They have to be premenopausal, and one caveat is they can't drink alcohol in it. Right? That's the caveat. So I'm going to just mention 2 things, because this is probably the most exciting thing in my lab and what we do clinically: stem cells. It is the way of the future. So we are one of only 8 sites in the country that take the fat from the man's abdomen, then we inject those stem cells directly back into the penile tissue. Those stem cells then turn into cavernosal smooth muscle. They increase angiogenesis, and they reverse the ED process. That's a cure, right? That's a cure. Viagra's not a cure, but this is a cure. So we have very good data. We also do the studies in the lab with the rats. But again, in the future, within the next 5 years, I expect you to see so much on stem cells for the treatment of ED. And real stem cells. So I'm not talking about a PRP, I'm talking about stem cells, right? This is also the newest. So this is called LIST. Low intensity shockwave therapy. It comes from Germany. It's just like when you do lithotripsy on a stone, now you do lithotripsy on the penis. Right, 2,500 shocks per week is what you're delivering, anywhere from 1,500 to 2,500. Extremely effective, because what it does is it increases blood vessels into the penile tissue and angiogenesis. And so we're starting a study here in September as a phase 3 study. So again, what's that?
Does it come in leather?
No, it doesn't. We can look into that. Well, it's low intensity, so it's a very low intensity. And so what it's doing is you're trying to induce a trauma to the tissue so that it will bring in blood supply and neovascularization, and it works. It does work. So comments on testosterone? Yeah, that's right. All of you are experts in testosterone, but I want to bring some things to your attention and that you may not be aware of. And so I'll just show you some quick data of what we're doing at Baylor. First of all, in 2015, the FDA put out a warning, and they said that 27% of men are abusing testosterone, which is somewhat true, because what they found was that the rate of testosterone utilization in the U.S. compared to every other country was ridiculous in terms of its growth, but our testing was going down as our utilization was going up. Right? So you're starting T without testing someone on T, or when they're on T, you're not following their levels, right? Obviously, that's occurring in certain clinics throughout the country, right? So there was a significant amount of abuse. So the FDA said, we're going to put a warning. We're going to put a warning, and we're going to say that you cannot use low testosterone in men due to aging, and I'll tell you what that means, even if a man's symptoms seem to be related to low testosterone, right? And they also want them to say that it could cause a heart attack or a stroke. So what does that mean? So if you look at the package insert, this is the package insert off of every single testosterone product. And it doesn't matter what you use. An anthate, cypionate, doesn't matter what you use. This is the package insert. And these are primary hypogonadism and secondary hypogonadism. And these are the conditions: testicular failure, orchitis, Klinefelter's chemotherapy. So let me just make it clear. If you are not treating somebody with this medical condition, you are treating someone off-label, right? Off-label. That is off-label utilization of the medication, right? And they should be counseled appropriately, maybe even consented on an off-label utilization of a medication. So how many of us are actually treating men on-label? Actually, it's pretty low, because 89% of patients who come in do not have these medical conditions. They do not have these medical conditions, yet we're still giving them testosterone, and maybe we should tell them it's off-label use. Maybe we should consent them. You would do that for any other drug. If you gave a woman Viagra, you'd have to tell her this is not meant for women, and it's off-label use. So it's a different paradigm, because when a guy walks in with ED, fatigue, low libido, in my mind, I was like, that's a no-brainer, right? He needs T, but there's no data to support that, particularly the FDA's eyes, right? So that is off-label usage, and that's what we're all doing predominantly, right? There are 4 controversies. I'm not going to go through all of them, but I just want to touch on prostate cancer and cardiovascular disease briefly, because every single patient will walk in and say, I Googled it, and I heard that testosterone causes prostate cancer. Where's the data? Show me that it doesn't, right? And so if you go to any country, the #1 concern is, I do not give testosterone because I am worried that testosterone causes prostate cancer. That's what the physicians say all over the world. I will not give testosterone because I'm worried that it will cause prostate cancer, and it may cause some BPH symptoms. The problem is it started in 1941, Huggins and Hodges. 1941, they had a seminal paper, and I urge you to read it. In that paper, it said that reducing testosterone to castrate levels caused prostate cancer to regress. If you gave testosterone to prostate cancer, it caused it to grow. 1941, seminal paper. The problem with the paper, it's based on one single patient. One single patient in 1941. If you said, Kara, I would like you to show me the article that testosterone causes prostate cancer. Can you show it to me? There's not a single article on PubMed that shows that testosterone causes prostate cancer. But it's the #1 concern in the world, and that's why we don't give it. It's just something to think about, right? Not a single article in PubMed would be able to show it, right? So we give a lot of testosterone to men after radical prostatectomy. I started doing it early after my residency in 2009. We had a follow-up study. Just briefly, because it's controversial. People say, look, you know, he had prostate cancer, and how could you give him testosterone? That could cause his cancer to come back. You should be very careful. Well, in the first 3 studies, we had no recurrence of prostate cancer. And the one that we published in 2013, we had 4 patients that had their prostate cancer come back. That is true. 4 out of 103, right? In fact, just to show you the study, we actually treated, we had 103 patients, 49 controls, but we treated patients with high risk, which is really unheard of. Gleason 8s, positive margins, lymph nodes that were positive with testosterone, right? And this is our study. 77 patients were intermediate risk. We had 26 patients that were high risk with testosterone in the control group, 34 men non-high risk, 15 men were high risk. The biochemical recurrences were only in men with high risk. That makes sense. But if you took testosterone, the recurrence was 15%. If you didn't take testosterone, it's 53%, right? If you took 50, it's 15%. And the clinchers, this is 3 years. 3 years after radical prostatectomy, that's too low. 15% is way too low of a biochemical recurrence, right? In fact, if you look at all the studies, the abstracts, if you count all the patients that got testosterone, I can count 386 patients. The biochemical recurrence is only 6 men, 4 which are high risk, which I showed you, right? 1.5%, too low. It's too low of a recurrence rate, even in a favorable group. Every time we submit the manuscript, anytime we submit, the reviewer always says to me, this is ridiculous. Are you suggesting this is protective because your rates are too low? It's a very interesting thought, right? There is data to suggest that maybe testosterone is protective. Now I'm switching at 180 degrees now. It's protective against prostate cancer. You give testosterone to androgen receptors, they get apoptosis. The most important study was CHOOSE study. Why is CHOOSE study important? Because CHOOSE showed that if you have a androgen-resistant prostate cancer and you give it testosterone, you can turn it into an androgen-sensitive prostate cancer. Very interesting basic science study. So I had the privilege of giving grand rounds in Johns Hopkins last year, and I met Dr. Den Mead. And you know what Dr. Den Mead does when he has patients with metastatic prostate cancer? He gives them high doses of testosterone. Can you imagine? So FDA-approved trial, you come in with metastatic prostate cancer, and your treatment is high doses of testosterone, right? He published it last year, and it's called bipolar androgen therapy, or BAT, where these patients were castrate-resistant prostate cancer. They were treated with 400 milligrams of testosterone every 3 months, but they were on an LHRH agonist. So you get high doses of T, then you come down and crash. High doses of T, and you crash. 50% of the patients had a reduction in PSA. 50% of patients had significant improvement radiographically with improvement of cancer, right? This is unheard of 10 years ago. And again, it's a very different way of thinking about testosterone and prostate cancer. Yes?
Occasionally we'll have patients who have high PSAs when they're on testosterone.
Yes.
And more often it goes down.
Yes.
Back and forth. What's your thought?
So I'll tell you exactly what's happening. I don't have a slide on that because I was trying to keep it condensed, but it's called the prostate saturation model. We published this on 2011 as well, Abe Morgenthaler as well. The model states this: if you look at a graph with testosterone and PSA, we used to think the more testosterone I give, the greater the PSA. That's called a linear model, okay? But that's not what's happening. At some point, the prostate saturates. It takes up all that it wants, and it does not care if you raise the testosterone any higher. We believe the saturation is around 220, 230, but everyone's different. So if you take a patient starting at 300 and you put them on testosterone and you raise them to 3,000, which has been done in many studies, no change in PSA. No change in PSA, no change in prostate size. But if you give that same patient Lupron and shut him down below the saturation point, he'll go to 0. But what you're seeing is you're treating patients right at their saturation point. I treat them, they go up. I take it down, they go down. I treat them, they go up because they're on the curve, right? Once you treat them and the PSA goes up, sit there for a while. Sit there for 3 to 6 months, and what you'll see when you recheck it is it's going to sit there. It's their new baseline, right? But the problem is you're treating them on the curve and not when they've stabilized. Try it again in 6 months and see what happens. So just a couple of things from our lab. So we do a lot of basic science work, and I told my tech, I said, I want you to do this. I want you to take prostate cancer cells, and I want you to put different degrees of testosterone in those prostate cancer cell dishes, right? So we did it because it was never published. So if you look at any line, if you take prostate cancer cells and you put testosterone in it, they grow. That's true. It's a little concerning, right? But the higher the dose you give, the greater the suppression, right? We call it the inverted U, right? So the higher the dose you give, the greater the suppression. And so if you look at the cancer, this is LINCAP cells with no testosterone. You give them a little bit of testosterone, they grow. That is true. But when you give them higher doses, it decreases the growth, right? So we published this several years ago. So again, it's just a different way of thinking. That's all I'm trying to do is provoke the mind to think, you know, where do we get testosterone causes prostate cancer? Just a different way of thinking. We have the only randomized placebo-controlled trial in the country because we wanted to treat men. Yes?
So when you're giving them high doses, I mean, you're speaking to, in the studies they're recording the dosing. Are they actually recording levels and measuring these men?
This is an animal study, right? Is that what, this is, so these are mice.
Right.
Rats, excuse me.
But the Johns Hopkins.
Right. Oh, yeah. So they're getting a super physiologic level because you're getting 400
so
milligrams.
He's taking them to super physiological
400
levels.
milligrams. If you check any man after 400 milligrams IM in 72 hours,
right,
it's going to be pretty high.
But then it's going to drop.
But then it's going to drop, and when it drops, he has him on an LHRH agonist the whole time, so it actually wants it to be 0. And he's just tricking the cancer, right? High then low over a 3-month period called BAT, bipolar androgen therapy, right? And that's what he's doing, and he's seeing results. So this is our study. We fought with the FDA pretty hard because the FDA said, we will not let you treat men until 1 year, until you've shown us that they have no PSA recurrence. And we said, absolutely not, because in my world, the recovery is within the first 6 months. If you do not treat that patient within the first 6 months, you miss the window of rehabilitation. So they let us start treating the patients in 3 months. We have to have 2 undetectable PSAs. We have to have at least 3 + 4 or less. I can't treat a 4 + 3, right? And the reason I put this up is many physicians say, can I treat men with testosterone after prostate cancer? I said, there's no data. But if you want to use a guide, you can say, I know there's an FDA-approved trial. This is the criteria they use to treat men with testosterone. And maybe you can use the same thing. It just gives you something to hang your hat on as something to say, okay, fine. But there's not a lot of data out there. We have treated some men with active surveillance because it's a big movement. So how could you treat men who are on active surveillance with testosterone? They have cancer, right? So this is a small series. Most of the men had Gleason 3 + 3. One had 3 + 4. Not a single patient at the end of the year had an increase in their PSA. On rebiopsy, we couldn't find cancer in 54%. And so what we put in our conclusion was this. There's not been a single study today, not one, to show that the incidence of prostate cancer in those men being treated with testosterone is higher than those men not being treated with testosterone. That is true. Not a single study. But you know that the risk of occult prostate cancer in the community is 1 in 6. In fact, when we did a study in the morgue, 1 in 3 patients have prostate cancer on autopsy, right? But they're not lighting up, right? So I can promise you, if you are treating 60 patients in your practice with testosterone, I promise you, you are treating 10 patients with active prostate cancer. I guarantee it. I guarantee it, but they're not lighting up. And all we wrote in this conclusion was we are doing openly, whatever all of you are doing blindly in your practice, and we still said the same results. There have been some follow-up studies after this on active surveillance with no increase in prostate cancer, on active surveillance with testosterone. So again, I mentioned this, it's important to get the testosterone early. The window is the first 6 months. Last comment on cardiovascular disease. There's not a single person in this room did not see these ads and commercials that you're entitled to compensation if you had a heart attack, right? I want to set the stage for a second. Before 2010, study after study after study showed that if you have low testosterone, you are going to die from a heart attack or stroke. That's what they showed. Study after study. In fact, there were 49 studies, prospective studies, long studies saying that if you have low testosterone, you are more likely to die, and the #1 cause of death is a heart attack if you had low testosterone. 49 studies before 2010 saying if you give testosterone, you may improve cardiac function. But something very interesting happened in 2010. Basaria came out with a study called the TOM study in 2010. Then Vegan came out with the JAMA study in 2013, ZOO, and then the Finkel study. And because this came out in December of 2013, and because this came out in January of 2014, the FDA said, these are pretty close back to back. We're going to start an investigation. We want to see what's going on. The second you start an investigation of the FDA, ads go up for lawyers, right? Because they think it'll go to court and they can sell the patient. So the ads went crazy in the beginning of 2014, right? But I'm not going to spend the time going through the significant flaws with each one of these articles. But I want you to realize, to set the stage, this is where the fear came from. That's it. You're looking at the whole page. There's nothing else to offer you. And every study that came out after this showed that testosterone was protective. So if you look at a graph, this is just a little blip, right? All it is just a little blip in the graph. We are now doing a large, it's a large study looking at cardiovascular disease. It's a multi-center national study. The FDA has required it, that industry do it. But again, it's about 2 years away. One last comment. We actually looked at every paper from 1939 to 2015, every single paper. This is the largest meta-analysis we did. We published it in the Mayo Clinic Precedes, and we found no risk for cardiovascular events. In fact, we found it to be protective, if anything. I'm going to just one more comment on testosterone. We have patented a technology called nanotechnology. You may have heard of it. Nanotechnology basically means a slow release, like an hourglass, right? So if you look at Testopel, or those pellets, they go up and they come down over 4 months. Nanotechnology is a slow, constant release. So this chip will be implanted into the side of the hip. It will slowly release testosterone. What's really cool about it is that what you can do on phase 2 is that you can remote control the increase or decrease the dose from outside the body, like you can with a pacemaker. So if the levels are too low, you up it. The levels are too high, you can down it. Yeah. So okay, so we're going to wrap it up. The last topic is the last 3, and they're pretty quick. Peyronie's disease, a very common disease, first documented in 1743. 9% of men will have it at conservative levels, 7% of men. That is a lot of people. 7% of men are walking around with an abnormal curvature of their penis and they're not saying anything, right? That's a lot of patients with this condition. Why does it occur? It's from sex, right? The more sex you have, the more trauma you have. Sex is traumatic to the penis. That's what it is, right? It's trauma. The problem is that the patient undergoes a buckling trauma. So if the penis is 100% rigid, no problem. If the penis is 50% rigid, you can't penetrate in the first place, right? But if you're 70% or 80% rigid, you're in trouble. You're in big trouble because you're going to buckle. You're going to buckle during sex, and you're going to make a plaque in the tunica albuginea, and you're going to curve, right? And so that's the patient that you got to be very careful of. Remember that when the penis gets 60 degrees or greater in curvature, it's prohibitive for intercourse, right? So if it's 60 degrees or greater, it's prohibitive. So clearly, this is a condition that needs to be addressed. Patients will say, Doc, I feel a knot in the penis. I feel something in the penis. My penis is curving. Is there anything you can do for me, right? They're telling you they got Peyronie's disease. Typically, most of the curves are going to be on the dorsal aspect, so it's a upward curvature is what they'll describe. If it's a kid that comes in, he's 20, 22, he's had it, he'll say, I've had it for a long time. He probably has congenital curvature, and it's down, right? So adults are up, kids are down, right? Typically congenital curvature. But the problem is that it's strongly correlated with ED, and most of these guys tell you they have ED before they have the Peyronie's, right? So they're 70, 80% rigid, they're buckling. That's the issue. A lot of causes for Peyronie's disease. Number one is being trauma. Low testosterone has been implicated as well. We published that as well. But there are many causes, but the reality is we really don't know. So this past year, I was part of the AUA guidelines, and we wrote the guidelines, our first guidelines ever on how to treat and diagnose and manage Peyronie's disease. And I'm just going to give you a high-level picture here. There's something called the active phase. So the guy gets Peyronie's disease right now. He's going to tell you, I have pain, I've noticed a curve. That active phase is going to last about a year, 1 year. And you do not do anything surgical. You only treat him medically. And you tell him the rule we tell every resident, it's the 15, 40, 45 rule. You tell him you have a 15% chance it's going to get better over the year. You have a 40% chance it's going to stay the same. And there's a 45% chance it's going to get worse this whole year. And just get ready for it. That's what's going to happen. And we're going to treat you medically. After that first year, it's the stable phase, and then you can operate on the patient. But you cannot operate on the patient in the active phase. Because if I operate on the patient in the active phase and he continues to curve, then I got to operate on him again, right? So you want to wait till he's stable and there's no curvature. So you can tell them these are the statistics. These are the things that we can offer you. Now, and remember, this phase is associated with pain, right? This phase is usually associated with no pain at all. But typically he'll say I have some pain and a lump in the penis. A lot of treatment options. The ones I'm going to just focus on quickly are collagenase, and it's called Xiaflex. It's the only FDA-approved treatment in the world to treat Peyronie's. There's nothing else that's approved for this condition. Zero. Okay? You can use these orals. They don't work very well. You can use a penile stretching device. They do help a little bit, but the only improvement is an injection. So I tell patients, if you're willing to come see me 8 times in 12 weeks, we can put the injection in. You'll see about a 40% improvement in curvature is typically what we'll see. If you're not satisfied, then we'll do a surgery called application, basically putting stitches on the opposite side of the curve to make the penis straight. And those are the options. A comment on delayed ejaculation. These guys come in and say, I can't orgasm. You know, it takes too long to orgasm. And so what really is occurring here? It's an imbalance between the neurotransmitters. So what we want to do is what's happening is serotonin, opioids, prolactin is going up, and the good ones are coming down. So all the pharmacotherapy is focusing on increasing these right here, increasing dopamine, increasing oxytocin, so that the patient can then once again have an orgasm. So these are the most commonly used. I use a tremendous amount of Dosinex. Dosinex is a dopamine agonist. We typically use 0.5 milligrams twice a week. Typically with increased dopamine, it can decrease prolactin levels. You can use bupropion, you can use oxytocin as well. These are the most commonly used therapies. Remember that when a patient has an orgasm, dopamine levels have to go up. It's a very simple concept. Dopamine levels don't go up, it's very difficult to orgasm. So the man's having pleasure, woman's having pleasure. As his or her pleasure is going up, so is the dopamine level. It gets to what we call a tipping point or a level where it turns on the signal, and then you have an orgasm, which is resulting in a significant drop in dopamine, a significant increase in prolactin, right? So we want to increase the dopamine the best we can. We use oxytocin too. I typically use the lozenges, 250 units an hour before sex, but typically these are some of the medications we use. I do use sometimes yohimbine. Okay, I'll tell you why. Yohimbine is from the bark of a tree in Africa, and there's some data to support that using yohimbine actually increases an orgasm. Has a little bit of cardiotoxicity, so you want to make sure that the heart is okay, but it does work in many patients. And then we, also for these patients, sex therapy, but a vibrator, a male vibrator is very effective in helping them be able to orgasm once again. It's a 1 minute on, 3 minutes off, 1 minute on, 3 minutes off, and that therapy has been shown to be effective. And then finally, premature ejaculation. Everyone thinks ED is the #1 sexual dysfunction, but it's premature ejaculation. It's the most common sexual dysfunction in the United States. Affects up to 35% of men. It coexists with erectile dysfunction. We use a stopwatch in our studies, so we have them start the watch, they engage in sexual activity, they stop it, because you can never really trust whenever the man and the wife tell you the numbers is always different, you know, in terms of the minutes, you know. But the average man will orgasm, if he has premature ejaculation, in less than a minute. 90% will orgasm in less than 60 seconds. Typically, it's about 1.8 minutes. And the average man who does not complain about premature ejaculation, orgasm is about 7 minutes in the United States, right? So the difference is from 1 minute to 7 minutes. And that's how you define premature ejaculation. Most commonly used is Promescent spray. I use that. It's over the counter. It's on the internet. It's the only one that penetrates the stratum cornea, right? So it gets into the stratum cornea. It's very effective. They put the spray on 10 minutes before sex. They wipe it off. It numbs the penis so they can go much longer. We use tramadol. This is off-label use, but you know what tramadol is? 50 milligrams 2 hours before intercourse. Mechanism unknown, but it prolongs the ejaculation significantly in many patients. And then an SSRI on demand or daily. Daily, if you take it on demand, it's 6 hours before sex, which is a long time. But on demand tends to work very effectively, but there are problems with SSRIs as well. And thank you for your attention. I know it was a lot. Any questions or comments? Yes.
What's the mechanism? Some of the guys that start on testosterone will start to have erectile dysfunction issues after starting on.
That's interesting. Typically, you wouldn't expect that, right? So you start someone on testosterone and start getting ED afterwards. There's no mechanism to suggest why T would cause ED, but there's a psychogenic component as well. You know, when these guys have ED, the mind has a huge impact on them. You know, when a guy, even a young guy, when they have a little bit of ED, you know what they do when they have sex? The next time they have sex, all they do during sex is say, I hope it doesn't happen. I hope it doesn't happen. I hope it doesn't. They're so perseverated on the fact that I hope it doesn't happen. It's a guarantee it's going to happen, right? And then if it happened the second time, the third time, they say, I can't believe it happened twice. That's all they're saying in their mind, right? And they're more, it's called a vicious cycle, right? And so sometimes there's no mechanism to support why T would cause ED, but you have to ask yourself, is ED already the picture? Are they hoping that the T would be solving the problem, but it's not? What's happening psychologically to these patients?
So you're thinking maybe they already had it but didn't say anything?
Possibly, possibly. But there's not a scientific mechanism to explain why they have ED. I take that back. There could be one slight exception. If the levels get too high and the estradiol level gets too high, it can have a negative impact. That's the only, that's true. That can happen. Yeah. Yes.
I've been using hyper-rich plasma injections into the penis for the last 2 years.
Yes.
I've actually started combining it with radio waves. I might try that shock wave.
Yeah.
I've had really good results. I mean, people get like 80% better after 3 treatments.
I've heard the same thing. You know, I don't have a lot of experience with PRP in the penis. You know, I'm moving more into stem cells, but there's some data to support that the combination of stem cells with PRP is even more effective than stem cells alone. You know, Erwin Goldstein, yeah, if you do the combo, much more effective than just using stem cells alone. Yeah, it's very interesting. Yes?
Will you share your slides with us?
Of course, not a problem. Be happy to.
So what do you do with the men that are hormonally manipulated after prostate cancer? You don't touch them, right?
Great question. So a guy comes on, he's been on Lupron. The reason he was on Lupron is because he had a high Gleason score, right? So if a guy comes to me and he had a radical prostatectomy, Gleason 3+3, would never give him Lupron. He's going to get radiation, and he has a Gleason 4 component, he gets Lupron. So there's 2 sets. Are you referring to the radiated guy or the radical prostatectomy guy? Which one?
Both.
Okay, both. So because they're trickier, it's a little bit different. So the radiated guy will never have a PSA that's 0. And you're always wondering, is the cancer still there? It's not. I wait 18 months and then I biopsy him and I consent him. And if it's reasonable, then I will start him on T, right? But he gets a biopsy, you have to wait 18 months, so there's a nadir. If you biopsy somebody before 18 months, you'll pick up cancer still on the biopsy, right? So it's too early. Wait 18 months, you biopsy. If it's negative, then you consent and say, look, the risks of prostate cancer progression and recurrence are unknown, and the patient still wishes to proceed. That's what the Baylor legal team asked me to put in each one of the and it says the patient states that he understands that the risk of prostate cancer progression is unknown and wishes to proceed. So that's what I do for the radiated guy. The radical prostatectomy guy is a little bit easier because the PSA will be undetectable, say 0, right? And so you have nothing to biopsy, and we have a discussion. Let me give you the best example. Let's say you had 2 twin brothers, okay? And they both had a radical prostatectomy, but one got Lupron and one didn't, okay? And the Lupron guy and the brother walk into the office, and the guy that got Lupron, his testosterone is 100. He says, I feel lousy. I feel horrible. You put me on Lupron, it's the worst feeling ever. And the other brother comes in, his testosterone level, let's say, is 400, okay, 400. And you tell the guy that's been on Lupron, you say, you can't get testosterone. It's very dangerous. But he's going to say to you, my brother's is 400 after the radical prostatectomy. The reality is that in urology, we leave the guys that are normal. Let's say the guy after Lupron rebounds. We let him rebound. We let him sit at 400. If he doesn't rebound, we don't give it to him because it's too dangerous. You got to pick. If it's dangerous, everyone gets castrated. If it's not dangerous, you can raise everyone back to the normal level. But we don't do that. We leave the lows low and the highs high, right? Which just doesn't make a lot of sense. Doesn't make any sense at all, right?
But that goes back to Morgan Keller's work, right, when he studied that in.
Right. So,
So-
he did that. That's true. I work with him a lot. If you saw a lot of those papers we did together.
Yeah, that's one blue Bible touch is if they've got one.
Yeah, so if they is right. So the argument is that they were given hormones in the first place because they were a more aggressive disease, and so why would I get into the business of taking that risk? The reality is many of those guys will recur anyway, and they may say the testosterone did it to me. So why would you want to take the risk? That could be the argument. It's a fair argument.
So you
Yes.
give testosterone to women, right?
Yes.
So there was a discussion that went around with some of the docs about androgen-sensitive breast cancer in women. Have you heard or come across anything like
I
that?
have not.
Okay.
I have not. I mean,
Neither
I don't.
have
I
I.
don't. I don't
So-
look. Yeah, it's not something I take into consideration when I give them testosterone.
So I've been really trying to study that.
Yes.
I have been using a product called NO40, which is a beet extract of sort that
Sure.
increases nitric oxide. I think it's Dr. Brian kind of into that.
Does it induce nitric oxide? Is that what you said?
Right.
Okay,
It
good.
increases in a natural way your nitric oxide
Sure.
in your body, and you can use little strips under in the saliva, and you can measure, at least to some extent, if people are high in nitric oxide or not. I've
Sure.
had several men that I put on this, and they say it really helps their erections. And perhaps it may also help when they do use Viagra,
Yeah.
because they have their natural reservoir, and this
Yeah.
is just trying to.
I couldn't agree with you more. I'm a big proponent on what you just said. I think it's extremely important to induce and promote nitric oxide within the body. It increases the efficacy of the drugs. I do it a little different, but I think there's many ways to do it. So I don't believe in giving someone a nitric oxide booster. I want them to make their own nitric oxide. And so what I do is I give them three things. I give them arginine, carnitine, and citrulline. And if you look at them from chemistry, if you add those together, that equals nitric oxide, right? So they're missing the substrate. So I give them arginine, carnitine, citrulline, and I let them make their own. There's a company that put those three in there in one capsule with some magnesium and zinc, because 80% of men are deficient in magnesium and zinc. So I tell them, just go on Amazon and buy that product. And I think it's going to help you with your PDE5 inhibitor medication. And just in general, it's not just about the penis, it's the heart, it's nitric oxide, right? So I think it's very helpful. Any other comments? Thanks so much. Thanks so much. Appreciate it. Thank you.